All right, welcome everybody. It's Friday, July 23rd. This is the July meeting of Health TechNet, and my name is Nick Van ter Hayden, and I am your Zoom host for the day. Just some quick reminders. Chat is not private, so please be aware of that, even if you think it's directly with folks. Please keep control of your mute button. You have the capacity to mute, and I would appreciate it if you could use it. The session will be hosted and moderated by Deanne throughout, and it is being recorded. I'm actually in a non-third party or second party recording state, so actually maybe I don't even have to tell you folks. I don't know how that works, but anyway, it's being recorded, so please be aware of that. And if you've got questions, please try and coordinate accordingly. Deanne will call on folks. You can raise your hand, put something in the chat, it will appear in the chat, or indeed just speak out, but it can be easier if you just let people know. Otherwise, I'll hand over to Jim and take things from there. Jim?
Thank you very much, Nick, and welcome everybody. Just one or two general announcements, and then I'm going to turn it over to Deanne. The one thing I want to highlight for everyone is that in August, we will be having what has become an annual event of a purely social event. And the main significance of August is that for the first time in over a year, we will be joining in person. We will be meeting for lunch at a pub in Great Falls that David has arranged. And I'm going to ask David to mention that in just a moment. I also want to alert you to our upcoming September meeting, which is going to be a significant meeting with George Mason University. Well, that will be hosted on the 23rd of September, which is that'll be an evening meeting at the GMU Arlington campus. And more detail will be coming about that, but we've invited the Chief Information Security Officer from CMS to speak with us about the Biden administration's approach to cybersecurity in healthcare and various ongoing issues in healthcare cybersecurity. So we're expecting a pretty interesting meeting. And David, do you want to talk just briefly about plans for August?
Sure, Jim. It's August 20th.
Right.
You can arrive as early as 11:30 if you'd like to. It's going to be at the Old Brogue Irish Pub, which is in Great Falls. Anne is nodding as though she hangs out there a lot. I certainly do. Anyway, it's right in the middle of Great Falls, which is a fairly small town. You just take Georgetown Pike west from the Beltway, a few miles. And the Old Brogue is pretty easily visible. It has a very large sign. And if you can find the post office, which is near the intersection of Walker Road and Georgetown Pike, the Old Brogue is right to the left of the post office. It's a free lunch, and we haven't been doing lunches, of course, this year and going well back into last year. So this will be the first time we'll be able to get together in person. One of the ground rules is that talking about healthcare technology is discouraged. The whole idea is to take a breather, take a break, and get to know each other better, talk about vacations and family, show pictures of your grandchildren or your children if you'd like, and just come and have a good time. We do have to leave by 1:30 due to a subsequent engagement in that room, but that should give us plenty of time to relax. So this has always been a very enjoyable event. We've been doing it ever since the very beginning. And we do it this way because for the most part, a lot of people are away on vacation. So this is a way to get together in a slightly smaller group and just have fun. We will send out an announcement with the details. So you'll get that in advance as well. So there you are.
Thank you, David.
All can come.
Look forward to seeing as many of you there as possible. And with that, let me turn it over to Deanne with thanks for arranging this month's event. And thanks to the speakers for joining us. We're looking forward to it. So Deanne, I will turn it over to you for introductions and to moderate the event.
Great. Thanks, Jim. I am so happy that we were able to cover this topic and that we were able to get a special guest speaker from the Marshfield Clinic System. But first and foremost, I'll just go over the order. With me today is Matt Kepler from my team. He is Senior Manager of State Health Policy. He's actually based in the Midwest, right outside St. Louis, and he has been tracking telehealth across the states really since he got here in February. We sort of made him drink from the fire hose on this one. Special thanks to Matt because he just moved his house yesterday, so he's joining us, I'm sure, amid a bunch of boxes. Our special guest speaker is Dr. Narayana Murali. He is Executive Vice President of Care Delivery and the Chief Clinical Strategy Officer of Marshfield Clinic Health System. He also serves as the Executive Director and President of Marshfield Clinic, Inc. In these roles, he works in coordination with the Marshfield Clinic Health System's Chief Executive Officer and oversees the clinical care delivery, research, and education of the 100-year-old physician-led Marshfield Clinic Health System. I should also add that I have the pleasure of working with the CEO of Marshfield Clinic, who is a member of the Healthcare Leadership Council, as well as sits on the board of eHealth Initiative. It is really a great group. So I'm so happy that he's able to join us. I also wanted to mention, because I know this is of interest to this group, that he also serves as the prime site principal investigator of the Wisconsin Consortium for the All of Us Research Program, which of course is the historic effort to gather data from 1 million or more people in the US to accelerate research, improve health, and deliver precision medicine. There's so much in his bio sketch, I could go on, but one other thing I wanted to mention is Dr. Murali actually testified in May on this topic in front of the Senate Committee on Finance. He was representing America's physician groups, and needless to say, really knows his stuff, and I'm happy that he's able to join us and comment not only on what the clinic's experience has been with telehealth to date, but also what they're thinking for the future and implications for revenue cycle management. I'm going to share my screen. Matt and I prepared some slides, so ask for your patience while I find the right window on my computer for that. I know I definitely am looking to be back in person, so I don't have to sit here and struggle to find my correct slides. Can you see something yet? There.
Hey, Diane, this
Yes.
is Richard. Well, you're putting up the share screen. I just want to do a shout out to Dr. Murali as well. Just to let him know I've actually been started up a collaboration with one of his researchers who's currently India based, Dr. Neil Shimpy.
Oh,
Great.
That's fantastic.
So we'll have to connect on LinkedIn and stuff, but I guess it's a small world when I saw the speakers for this this session. So very nice to meet you.
Likewise.
Are you able to see the screen? Yes?
Yes.
Okay. All right, I didn't hear that you can't, so I'm assuming it's there. So I wanted to give like a level set of where we are with federal telehealth. We all know that it escalated exponentially in the beginning of the pandemic. And where are we today? So I looked at some McKinsey data, and really when we looked at the beginning, outpatient telehealth and office visits 78 times higher than the previous year, and $250 billion was McKinsey's estimated last year of US healthcare spend that could potentially be shifted to virtual or virtually enabled care. So fast forward to this month. McKinsey is saying that we've now stabilized because, of course, a lot of this has dropped off and gone back to in-person care. And where are we now? Well, they're saying we're at 38 times higher than before the pandemic. So as the former CMS administrator said, the genie is out of the bottle with telehealth, but what are we looking to do with it moving forward? There's a lot of policy decisions, both on the federal and the state side, that need to fit in here. So consumer and provider attitudes, what are they thinking? We're really thinking that models are likely to evolve into a hybrid. There will always be in-person care, particularly for emergent or procedures, but how can we augment that with telehealth? One of the big discussions has been, what is CMS going to do? They let a lot of things get waived in terms of site restrictions and payment restrictions and parity before the pandemic and during the public health emergency. But we really don't have clarity as to where the final direction will go once the public health emergency will end. And Matt and I will get into a little bit of that as well. We know that virtual healthcare models and business models are still evolving, right? There's not only talk about how to pay for virtual care, should it be on the same parity as in-person care, but also how do we fit this into pay for value, value-based care models. And lastly, I wanted to highlight that McKinsey's research shows that between 40 and 60% of consumers express interest in a broader set of health solutions, such as a digital front door, or even the concept of virtual first health plans, which would rely on telemedicine for a lot of services versus in-person health. Now, I wanted to shift to this Trilliant Health research piece. I invited Sanjula Jain, who wrote it, and unfortunately she's on vacation and could not join us, although she gave me full permission to highlight some of her research. So given that we are in this virtual environment, I'm going to try to see if I can actually share this page. And if I can't, I apologize for that. But I want you to look at the link, and starting on page 32 is really where I wanted to focus the most. Give me a second, please.
Are you going to be sending the deck out afterwards, or?
I will. Okay. Yeah. So if you want to pull up the link, because I'm afraid I'll mess up slide sharing while I'm doing this. But one of the things that she highlights in terms of telehealth on page 32 is really, I mean, first of all, this is great research simply because it covers everything in terms of trends in a post-pandemic health economy. I've circulated it internally here with my team because so much of it involves market planning, as well as what they're seeing consumers want and what different service areas are looking like in terms of demand and consumer focus. But I thought it was interesting if you look really at the telehealth specific in terms of where we are with volume, both emergency department visits and virtual care in terms of pre-pandemic from January 2019 leading up to the peak of the pandemic starting April 20 to post-peak pandemic, which is the first part of this year, as well as trends in Medicare. In terms of how different metropolitan areas are using telehealth, where is that really skyrocketed, and where is it not? The states with the least growth, such as North Dakota, Wyoming, Mississippi, Iowa, and Arizona, is that possibly because we don't have as much broadband there? Rural healthcare systems will tell you yes. The states with the greatest growth, California, Massachusetts, Oregon, Hawaii, and Vermont, definitely. I know back in grad school, I did a research paper in the late 90s about how sophisticated Hawaii was with their broadband and telemedicine back then. Why? Because it's really a disparate healthcare system with no chance of bouncing between islands very easily to go see specialists, right? On page 36, if you look, 6 markets with the highest percentage of growth were in California. So I think in terms of market planning, not only is this a good source of demographics, a great source of research, but I, again, and it was sad that the researcher couldn't be with us, but I wanted to do a shout out and share this with you because I think the data here, with regardless of how you're planning to use telehealth in your own organization or whether you're looking at measuring the industry,
Arizona,
trying to plan the future, I think it's really important research and very thorough. So I'll switch back to our slides for a minute, and then I'll hand it over to Matt once we get through the federal overview. So last week, of course, while I was on vacation, but nobody at CMS schedules with me, of course, they dropped the proposed physician fee schedule rule, and included in there are some important things about telehealth restrictions. And I can also add some color in terms of what I've seen being discussed in Congress. So back at the end of last year, when there was the known as the Consolidated Appropriations Act, or CAA, it removed geographic site restrictions from telehealth for the remainder of the PHE, or public health emergency, which really says payment is limited payment based on location of the originating site for individuals with mental health disorders. We've seen, of course, telehealth really be used the most for mental health disorders and substance abuse. And this is getting a lot more attention right now in Congress, because they're realizing that despite the pandemic crisis, the opioid crisis never really went away. In fact, it's increased and become worse. In the proposed rule, CMS is looking to retain certain services added on the temporary basis in last year's waiver, at least until the end of the calendar year 2023. So 2 more years really, or a year and a half to figure this out. There is a concern that before CMS makes final, before legislation makes final, opening up a lot of these restrictions on telehealth, they want more data. And I've heard the pros and cons about this. The pros is, we're really concerned about what is the most effective. We need to study this. And there's a lot of concern about how fraud, waste, or abuse could proliferate in a virtual only environment, particularly an audio only environment. On the other hand, I've heard policy specialists say, well, that's all well and good, but the government's always looking for more data. We're never making really decisions. It's always, well, we'll see, we'll see, we'll see. So, TBD on that one. But this is an opportunity for those of you that have a vested interest in this to comment on what appropriate services should look like outside of the public health emergency when it ends. There's some things in here on mental health. I won't read the slides to you, but a lot of this is, do we want to require someone to have at least seen a mental health provider in person within a 6-month period before we continue to have virtual only mental health visits? I know there's also been a lot of concern about audio only communication technology, not only for the real chance of increased fraud, waste, or abuse, but also how effective is that? Of course, it makes sense in places where there's not a lot of connectivity, or where the patient does not have access to broadband connectivity and or the capability for video. But CMS is really looking to see, how do we thread this needle between what's appropriate and what we can pay for? And by the way, we know we need to invest in broadband, but how do we look for the future in terms of what those future policies should be? In terms of Congress, there's an awful lot of bills that have been discussed. Some of them were mental health and telehealth focused, like the TREAT Act, and this one, the CONNECT Act, is really more broad-based in terms of what do we want to do with these restrictions that we know were relaxed. So the CONNECT Health Act, which it's to be decided how much this gets traction and moves later this year, but it would allow the secretary to basically waive current restrictions in Medicare starting on January 1st. A lot of that, of course, would include the limitations of, we need to have a provider in a specific originating site or within a geographic area close to the patient, the type of technology, the types of practitioners that could use and get paid for telehealth. A lot of leeway here. It's a pretty big bill. There's a lot of industry support, but most interestingly is that one of the key people that would need to back this, Senator Ron Wyden of Oregon, has yet to sign on to this. And part of that is because what's not included and what is included. So I've heard both sides of the story, that it's too broad, that we need more data. Also, that what's not included in terms of audio only parity, it doesn't address physician licensure in terms of how do we get people that are practitioners and clinicians that are in one state to be able to treat patients in another state. And Matt's going to touch on that because a lot of that does involve state law. It would also repeal the face-to-face visit requirement for mental health and substance abuse, which interestingly enough, might be at odds with what CMS is proposing in the rule that dropped last week. And of course, it doesn't include funding for infrastructure in terms of broadband. I'm not sure that's really such an issue. If you look at what the president is proposing in his infrastructure package, There certainly is a way that Congress needs to hash this out so that there's not duplications of policies here. So that's a quick overview of the federal landscape. I'm going to turn it over to my colleague, Matt, to talk about all of the different things he's seen on the states.
Thanks so much, Deanne. It's a pleasure to be here today. Appreciate the invitation. We've had a very, very busy year. There's been over 1,000 bills across the states related to telehealth. And so it's been a very active session, and wanted to cover a little bit about what some of the states are doing as a result of these public health emergencies, specifically the federal one that kind of opened the door for the states to take action and to find ways to provide more flexibilities, making it easier also for providers who are serving Medicare and Medicaid patients as well, related to some of the waiver changes that they've made. And also the opportunity, as Deanne mentioned, for providers to offer services across state lines as well. Of course, payment parity continues to be of interest for both Medicaid and on the private side. And substance use, controlled substances, has also been a hot topic as well. So during the federal public health emergencies, states also were allowed to establish their own public health emergencies, but many of those, whether it's through the waiver or through the order itself from the governor's office, have started to expire, or they're allowing to expire. So legislatures, some more proactive than others, as you would imagine, spent their time, making some of the public health emergency flexibilities for telehealth permanent. Next slide. So I put together a map of where we were at the end of June, but I suspect from what we were seeing in our research that there's going to be many, many more states that also are going to allow the telehealth state emergency to expire. Some of them were tied to the federal emergency, so they will continue if it, as expected, will go through the end of the calendar year, but time will tell. Next slide. So the impact of these, just pulled out 3 kind of case studies for note. Both Florida and New York, their emergency waivers for telehealth have expired. Out-of-state providers are no longer able to provide services in state. And the legislature could address these issues on the Florida side, but they won't come back into session until January. So you can see where there's an uncomfortable lag for patients in that time frame between now and the beginning of the new year. And New York is also their kind of unique features. They've allowed Medicaid to continue through the federal public health emergency period. So, it's kind of an imbalanced approach, in terms of what they're doing. And then Nebraska, had a couple of bills that they were able to get through their unicameral legislature. And, basically we're expecting, which is important, some coverage and parity, and also some originating site legislation coming from there. So something that was definitely a proactive effort in Nebraska. Next slide. So some of the themes that we saw related to Medicaid, private insurance, licensure, and broadband, just some of the categories that we pulled out. Medicaid, obviously states are constantly looking to manage their state budgets and their responsibility for services under Medicaid. And even though there's been an influx of money coming into the states for relief for COVID, they know that in the future, it's going to continue to lean heavily as Medicaid growth continues. So some of these flexibilities, as Deanne mentioned, include audio only. That was a lot of the activity in many of the states. Also expanding the types of services that are covered. Substance use disorder and behavioral health were the ones that skyrocketed, and so states took advantage of that. And then we're seeing the beginning of some payment parity for services delivered under Medicaid. On the private insurance side, really improving and maintaining access for coverage of services, really increasing the focus for payment parity more so than had been in the past, seeing if some more states be able to add that. And I'll show you a map here in a moment about that. But in health plans, some of the health plans were actually, many of them voluntarily waived member cost sharing for telehealth, which was very positive. On the licensure side, just really reviewing those state licensure and practice policies for really what type of health professionals are allowed to provide services. Some states broadened it, so it was just more of a general term rather than just physicians and nurses, et cetera. And then, of course, the interstate compacts as well. States like Alabama decided to go ahead and utilize and join 3 more of the interstate compacts. And also, as Deanne had touched on, the broadband, it continues to be an issue that is a major theme, as they had funding from both state and federal levels to expand access to it. And that will be something that we'll cover in a little bit here, talking about the trends in the next year. So I put the next slide. So I put together some visual representations just to give an idea of just really the number of states that had focused. And these are just a moment in time. You know, we continue to add to the numbers, but it'll give you an idea that they've all got a definition now, which is the first step for telehealth under Medicaid. And then they all also allow some form of live video as well. You can see the numbers for store and forward, you know, remote patient monitoring, and then of course the number of states that have all 3, but it gives you an idea that there is momentum and there continues to be work in the states. Next slide. So we put together a map, you know, based upon some information that Manat had started, and we kind of updated as time had gone on, but you can see that the number of states that have a permanent payment parity process, or at least those that have one with a caveat in place, is increasing. And so that's very encouraging. This has been one of the major issues we've been working on, we've all been working on, you know, in the states, and just want to give a visual representation of kind of like where we're at for this time period. Next slide. Same goes for, as I mentioned about Alabama joining 3 extra interstate licensure compacts. There has also been a lot of movement. Of course, the darker the purple, the more compacts that the state participates in, and the lavender color is kind of in the middle. So many of these states, you can see they're starting to trend more towards the darker purple colors, and seeing certainly how advantageous it is to participate in these interstate compacts. Next slide. So we put together some items that are issues right now. I think there will be more that will bubble to the surface as we would finish up our reports for states and where they stand. Some states are still, such as Illinois, have more time before the governor needs to take action. So you know, we don't know the full sphere of what they've changed in these states, but we do know, as I mentioned earlier, that states will continue to look for cost effectiveness and ways that they can use money in other ways, specifically related to Medicaid telehealth services, since that's such a large portion of their state budgets. Of course, broadband will continue to, you know, really take front stage, you know, in terms of the discussion so that the services can be delivered. Equity has been a major component that there just has been some work, but there hasn't been enough, and really need to continue to work to address these exacerbating health inequities. On the licensure side, you know, really whether they're going to be able to make some of these flexibilities for the temporary licenses permanent for out-of-state providers. Some states, such as Arizona, have a registration process that have gone into effect, such as what Florida had enacted back in 2019. And so that's where they have to go in and provide services and have an in-state registry they have to join to be able to provide services as an out-of-state provider. And then, of course, the prescribing issue, especially with the need for substance use treatment, and the rules that really center around the work the DEA is doing at a federal level. Next slide. So I have these, and Deanne mentioned she'll share these with you, but just wanted to share some of the states and some of the work that they've been doing, as they've been very busy, especially on the coverage and payment side. You know, some major work in Connecticut. I just pulled one of their bills, but related to Medicaid, you know, where they're, you know, providing coverage for audio only. And then, of course, they're going to provide those services at parity. Nevada had kind of an interesting piece that they included as well. Looking for the word they use, but they had a type of study that a dashboard. That's right. So they have a dashboard that they're going to be putting together that will provide for analysis of the data. And I think that will be a very interesting component. Not all states had something that was kind of forward thinking like that. But I do think that that certainly will be interesting to keep an eye on them moving forward. Next slide, please. Just a couple more. Iowa was very busy. Illinois, I've already mentioned that. They did a pretty big overhaul to try to take advantage of making some of the telehealth flexibilities permanent. Oregon also had a bill mandating parity. Oklahoma, which is good to see them working on some of the issues as well, starting to kind of open up their policies. Also wanted to cover on the next slide just some laws that are in the books. And I do want to reiterate that all of these except the Illinois one I mentioned are now law. So this is just really a thumbprint of all the bills that are out there. But in both Arkansas, which Arkansas had to arguably been one of the busiest states with telehealth flexibilities this year and new laws, but they allow for both Georgia and Arkansas now allow for audio only. And then they've also done some work under their definitions section to include home under originating site, which is obviously very important as well. Texas is another state that was very busy. They just recently had a couple bills, House Bills 4 I mentioned here and House Bill 5 as well, that really kind of opened the door for services. And you know, in typical Texas style, it doesn't necessarily cover all services, but it definitely starts to be able to cover, you know, some of the services, which I think, you know, you can get a starting point with a state that large. It's always a good thing to continue to keep that issue at the forefront. So Deanne, I believe you have the rest are in the appendix. We have put other bills that might be of interest to you that have kind of come out that have become law now, and just wanted to make sure that we mentioned them and put them in the slide deck. So.
Great, thanks, Matt. Very thorough. I'm going to stop sharing my screen, and Dr. Murali, if you want to go ahead and share yours.
Okay. Deanna, are you able to see my screen?
Yes, I can.
Okay, perfect. Thank you for those kind words of introduction. And as I was listening to the presentation that Deanne as well as Matt were sharing, there is a lot more to elaborate from the standpoint of this discussion. So what I'll try to do is I'll try to keep the upper part of the discussion pretty crisp and informal, and then we could go into a question answer session, because all of you folks have far more expertise than I do in that space. But I can share with you what we see in the space of healthcare, and particularly in rural America, what impact it has. So that with that introduction, let me just get straight to the meat of the issue. There is no doubt in my mind that COVID-19 as a pandemic continues to be a serious threat as you start listening to the Delta and the Lambda variants that are impacting us from the standpoint of the country. That said, while it actually opened opportunities in terms of how we provide care, I think I'm more concerned, depending on where Congress goes, that some of the vital advantage that we've had in terms of expanding care is going to be lost. And that is a very, very serious piece. And that was the same discussion we had at the Senate Finance Committee. And I think I understand, based on where Deanne shared, why Senator Wyden is still not signed the document, because in the information that we provided to him, and there were other experts, there are certain elements that are not captured in the present document. So to give you a sense of where Marshfield Clinic Health System is, we're in the middle of Wisconsin. We cover approximately about 45,000 square miles in terms of our geographic distribution. Practically 80% of rural Wisconsin is within our service area. And that's really how we've gone about it. And we've been in this business since 1916, covered about 60 clinical locations in about 39 communities. We have 10 hospitals that have all come into play in the last about 6 years. And we spend a substantial amount of time in both research as well as education. Presently, we have 1,400 plus providers, have approximately between 3.5 to 3.9 million encounters each year, with about 325 to 390,000 patients that are covered at any given time in a particular year. So it gives you a broad sense of where we are as an organization from the standpoint of our footprint. As you can see, we transition right up into the upper Michigan area, which is called as Hoopers, and go down right almost up to the University of Wisconsin in Dane County in Madison, and pretty much all over the geography in Wisconsin. Our health plan, which is part of our integrated health system, covers more counties than we do in terms of our clinical footprint. But I think from the standpoint of integrated care, we've been able to start thinking about how to provide care on a non-transactional basis. In my mind, any innovation that happens in medical care, because medical care is pretty slow in terms of taking risk from the standpoint of safety, any innovation that happens in a non-transactional setting. So if the country is looking at lowering the cost of care, so long as they continue to have a pattern of where you pay for more widgets or more things done on a fee-for-service model, you are not going to be able to achieve the ability to deliver on the value piece. And for us, the relationship with Security Health Plan, which is a community health plan that we own, has allowed us to focus from a not-for-profit standpoint as to what we need to do that is right care for our patients. So that is respect to the reach. And then I think it is important to understand when you're really thinking about middle America or rural America, which approximately is a population of 60 million lives in the United States, with over 2,000 hospitals, 40% of them that are at the risk of closure at this point because of how healthcare dollars are spent, it is good to have a sense of what rural America really is. So what you will see in the sea of red is basically talking to you about the labor to Medicare ratio. We have less than 2 workers per Medicare beneficiary. And so the population that Marshfield Clinic Health System caters to is the older, the sicker population, and by that notion have higher healthcare needs compared to the standard population that we have across. In addition to that, I think it is extremely important to recognize that almost 50% of the kids who are in this geographic territory are dependent on free school lunches. That gives you a sense of how poor the communities are and what kind of gaps that exist from the standpoint of social determinants of health. The median age at the Marshfield Clinic Health System compared to even the state of Wisconsin is older. The median income is much lesser, and the percentage of poverty is higher from the standpoint of the demographics. I think it will be good to put in perspective what happened from the standpoint of telehealth. And here I have numbers of the number of encounters Marshfield Clinic Health System had in terms of telehealth from the time of 2018, 2019 to when the pandemic happened. So approximately, we were doing about 3,500 visits prior to the pandemic. Within a week or two, we ramped up that because we had to close down facilities. We had about 6,500 encounters by about week 8. And before the end of the year, we were close to about 250,000 visits that were being provided purely by telehealth. So if you look at Wisconsin and you map it up based on the telehealth patients, because Deanne alluded to both the audio as well as the video visits, I want you to get a sense of the audio video piece. What you will see is in each of these little counties that are there in the zip codes, some of these counties do not have access to broadband. Most of the patients who live in these counties basically use flip phones. And so trying to do audio video combined coverage in rural Wisconsin will be an unmitigated disaster because you don't have the ability to provide the coverage on a broadband basis. And that digital divide is not much different than the what we call as the black belt of Southern America. That is pretty much what you would see in Middle America from the standpoint of the broadband divide. But regardless, I think it is important to capture the trend of care from the standpoint of telehealth and compare that to unique encounters. If you can see my mouse here, basically March 15, 2020, prior to the pandemic, we had roughly about 30,000, 31,000 encounters on a monthly basis from the standpoint of face-to-face visits. the number of telehealth encounters were only about 34. Now, when you multiply that over the years that we have done things from 1997 out of necessity, that translates to a reasonable number. In fact, in the country, we were supposed to have one of the highest footprints because we've been in telehealth, telestroke, tele-ED, telepharmacy, tele-virtual care because of our geographic needs. But what you will see is that by the time the pandemic hit in April, in about 8 weeks, we went from roughly about 3.5% of the population being seen by telehealth to approximately 22%. That's a phenomenal increase in terms of volumes. But then you also need to keep in mind that the face-to-face visits dropped. So this percentage is approximately about 15% of our total encounters that we provide from the standpoint of care. What you have on the right side of the screen is the missed opportunities. And what I'm really calculating here is over the calendar year, based on the assumption that you have established visits where patients come in for their day-to-day follow-up, where they do not need a lab investigation, but really need a visit from the standpoint of their basic biometrics, as well as counseling, that translates to roughly about 1 million encounters. So even though as the peak of the pandemic has settled and people have reverted back to the baseline of having face-to-face encounters, we know that there is a definite band for telehealth, and that's approximately about 15% of all encounters. So I hope I made the case about where it is. Now, you may turn around and ask me, why are the numbers trending down to about 6%, 6.4%? Not much different than what Deanne shared when McKinsey shared the uptick of the capacity to where they're trending as they go, or what's happening to Teladoc and Amwell from the standpoint of stock prices, is largely related that we are reverting back or regressing because there is no payment parity. There is no special focus on what's required from the standpoint of how you support the infrastructure to provide these services, and then how do you incorporate that into the work processes from the standpoint of care delivery. I also have a histogram based on the age of our patients as well as the gender of those who had in-person visits in light blue and those who had telehealth visits. And what you will see is that anywhere in the age group of 35 right up to the age group of 75, there is an increase in the uptick of telehealth. So it is not to do with education or your age or gender for that matter. In fact, women probably use less of telehealth than men do. Women probably have less loyalty to brands than men do. And these are some of the myths that have been exposed during this pandemic from the standpoint of care. But I think what is compelling is that I have had 90-year-old patients who have been on hospital at home care with an iPad, who once they got to understand how to communicate with their doctor as well as their nurses, did not want to let go of the iPad because they were able to actually have that access in a much more effective fashion. So I will shift gears to talk about where the future of healthcare is going and why it is important to recommend the telehealth piece and why policies need to be put in place. So one of the areas that I am particularly focused on is at the hospital at home programs. Back in about 2 decades ago, Bruce Leff and his group were involved in some of that pioneering work that was done in Hopkins as well as in the Boston area. But all of those were done on a grant basis. So you basically had NIH grants to do the hospital at home programs and you could support it. None of the early adopters were able to scale the program, largely because there was no payment for virtual hospital care. So in 2016, we in Marshfield Clinic Health System decided that if we needed to cover this wide geography and we wanted to avoid patients traveling multiple miles. I've had patients travel 200 miles to come and seek care from me for nephrology, for instance. And we wanted to actually improve, then we needed to figure a better way to provide care, largely for 2 reasons. One, the originating site definition, that is actually a big challenge because it requires that the patient is in a facility where they're able to be observed, as well as the physician has to be from the same facility. Right now, the way I see from the Health Act changes, it is purely linked to behavioral health. But the fact of the matter is behavioral health is a third of that bucket. You could provide the same for diabetes care. You could provide the same for heart failure care, chronic obstructive pulmonary disease, kidney diseases, all of these which are high cost to the country. And so the difficulty to scale was the absence of telehealth, the absence of a reimbursement structure. There was no incentive for us to adopt those models. And then there were limited opportunities to address that function and to document. So in 2016, Marshfield Clinic, along with Security Health Plan, our health plan, decided that we're going to do this on a commercial platform. And so we went ahead and partnered with a company called Contessa so that we could actually do all of the hospital level care at in a telehealth basis with our groups, and we broke them into 3 categories. Those that could be managed in a hospital as acute care, those that needed to complete their hospital stay after coming into the hospital, and those that were post-acute care, where you needed to put them into a skilled nursing facility, and you could avoid that by providing care for them at home. And what the model basically revealed is that when we compared to match cohorts of our patients who were in the hospital to cohorts of patients who chose to be admitted at home, the satisfaction for those patients as well as the outcomes were spectacular. And this is what led to the focus on actually writing a grant to CMMI during the PTAC committee, where we talked about the hospital at home concept. And what you will see is that in our studies, which we published in the New England Journal of Catalyst, there was a 37% reduction in the length of stay of these patients. There was a 44 to 50% reduction in the ER visits. Patient satisfaction rates were upwards of 90%, and the acceptance of these patients when they were offered the hospital at home program was upwards of 93%. We have subsequently had more follow-up of these, and what you will see here is our outcomes over the last about 4 years. This led to the transition of CMS allowing us to be one of the first 9 hospitals in the country to actually provide the acute care without walls program, and then required state regulations to address the regulatory components from the standpoint of Medicaid. Regardless, those results continue, and what we were able to show was that this is a very effective way where 15 to 20% of patients who require hospitalization for acute care, so long as they don't require a ventilator, can be managed at home. And this is a big deal from the standpoint of both outcomes, because there's no place to recover like home compared to a hospital. And you reduce post-hospital infection by about 10% as you provide such care. So I will pause there and address any questions that you have, and that discussion can flow into whichever space that you would want to address, whether it is with respect to broadband, whether it's respect to rural hospitals, whether it's respect to expansion of telehealth into telestroke, into tele-ED, telepharmacy, and I will leave it at that point. Deanne?
Great. Thank you, Doctor. That was a really good presentation. I enjoyed that. Yeah, I'd love to open it up to Q&A discussion. If anyone has anything, whoever wants to get us kicked off.
Yes, hi, this is Trish Marcus. I'm with Nelson Mullins in Raleigh. Thank you all for your presentations. I thought they were terrific. My initial question is for Dr. Murali. I'm wondering, you were talking about Medicare and Medicaid supporting the hospital at home program. And I wonder, how have Wisconsin private payers reacted to that service?
Yeah, so great question. Let me just make sure I'm able to get this streamed in for whatever reason okay. Yeah, so from the standpoint of private payers, we have close to about 4 or 5 insurance companies, including now Anthem and United, that are moving towards providing that service from the standpoint of hospital at home, not all of telehealth. And so in terms of the telehealth, there are different ways to break that, right? So you have phone care, which is telehealth. You have audio video care, which is tied to whatever decision CMS makes. if CMS insists on an audio video care, then most of these health plans are going to stick to that rule. And I think that that would be a bad idea because it would be an unmitigated disaster for care. In terms of hospital at home, I think there's been increasing number of groups that have recognized the value of hospital at home because today there are about 350 hospitals in the country that provide hospital at home care, where the focus is not heads in beds like an average CFO would think, but really focusing on where the best care and the best outcomes will be provided. So I hope I've answered your question. So for a commercial group, if it is hospital at home, they see the value because it lowers the cost of care. We have demonstrated impact on that. We do believe that telehealth, whether it's virtual or audio visits, can also lower the cost of care, with the concern for fraud and abuse always being there, but that degree of fraud and abuse is going to exist anywhere in the Medicare system, and we need to tighten the audit and compliance elements related to that. But it actually reduces the cost of care even in that space. And health plans will recognize that. So I'll give you a real life example. So if you're a diabetic and you were somebody who was focused on your own healthcare, all you need is a system which is basically able to check your blood glucose, upload it into the cloud so that your physician and the team can get back to you in terms of adjusting your medications. There is not a reason for a diabetic who is 200 miles in winter, drive through inclement weather to come and see me as a physician in a location that is so far from their home, right? So Livongo is a good example of what Livongo has been able to achieve in terms of diabetic care, for instance. I can think of the little old lady who used to have diabetes and kidney disease, who had to travel from Iron Mountain, 230 miles in winter to come and see me 4 times a year to manage her heart failure as well as her kidney disease. The moment we transitioned to telehealth in 2007, we were able to actually better manage her with infusion of diuretics as well as therapy. In a matter of 2 years, she was off seeing a kidney doc. To this day, it is 2021, I get a Christmas card from her, even though I no longer provide care for her. So it just tells you how much you can transform things and how much you can convince insurance companies to recognize the benefit, but CMS has to take the lead first. I hope I've answered your question.
Yes, very much so. Thank you.
Dr. Murali, I have a question from Jim Oakes. How often during the day do caregivers physically visit the patient, and how is that scheduled?
So if this is for the hospital at home, this is how it works. Let's say I am the patient. I walked into the emergency room or the urgent care or to an outpatient unit where I require hospital admission. A decision has to be made that that patient truly needs a hospital admission. Once that decision is made, then we ask the patient, are you interested in getting your care at home, where we will be able to provide you all of the durable medical equipment, oxygen requirements, IV infusions, day-to-day care. A physician sees you on the front end during that decision to hospitalize. After that, it is a home health nurse who has the skills of an acute care nurse who visits with the patient, is basically available to the patient in blocks of 4 hours in the morning and evening, and then over a 3-day period, that duration is reduced. In the hospital at home program, the way we do it is we think about an entire 30-day stay. So we're not really looking at acute care. We are really looking at how do you reduce ED visits? How do you make sure care coordination happens? How do you make sure nothing gets dropped from when a patient is transferred from the hospital? And most of the patients who are gone, we had over 1,000 patients like that who've been managed that way. Most of them will tell you that that is a Cadillac of care. Most of the adults who have their older parents receiving this care will basically tell you this is a life-changing experience. I'll give you an anecdote. I had an interim chief medical officer who worked with us, who was roughly about 74 years old. Complex diverticulitis, who required hospital admission with a perf. The decision was to manage him through antibiotics, not surgically, right? He walked into my office and said, Murali, I do not want to get admitted in the hospital. Figure out how your nurses can provide care. I'd rather be at home. So we got the antibiotic care for him at home. 3 days later, he was back in the office, which if I had kept him in the hospital, the duration or length of stay would have been probably 7 to 8 days. And potentially, he would have picked up C. diff colitis, which would be a hospital-acquired infection, because he's been exposed to much more. So there's a lot that can change if we are really open and willing to go down that pathway.
Yeah, I would agree. With one caveat being this isn't going to work for the homeless population, but I do think this has tremendous advantages. This has been really enlightening. I have
one question. So just a quick one. Just is there some? Have you been tracking? What percentage of patients who are cared for in the hospital at home have to be acutely transferred back? Something doesn't go right. You can't manage it at home. I'm sure you probably track that. Just curious where that
Absolutely,
settles out.
Kevin. And this is something that I'm very proud about, and that's why I'm evangelized. So when we started this program back in 2016, Susan and I had to go to Chicago. We were in the process of acquisition of a hospital from Ascension, and I was not willing to leave site because it was a major handover of care, right? And so Sue said, no, you need to come. So we went to Chicago to meet this whippersnapper, who was trying to sell the idea. And I told Sue, this is the craziest idea you can ever think of, because to make this happen, I need to work with home health organizations and clinical organizations. And she said, well, that's my dream, just make it happen. So that was where we were in 2016. Today in 2021, we have managed more than 1,000 plus patients at home. We've had one return of a patient who decided to go palliative hospice care, and we did not have the approvals to do palliative care at home, so we brought the patient back.
Wow.
0 returns other than that, 0. And then in complexity of care, we now manage close to about 150 diagnosis-related groups at home. We started with 6 conditions. Now we have close to 720 conditions that we can manage at home. So basically, if you don't need to be in the ICU, you don't need to have a ventilator, you don't need to have continuous intubation on a protocol basis, and you don't need pressors for hypotension or sepsis, you can be managed at home. And so my physicians have started to do that on a much more routine basis. We have a daily census of about 22 to 27 patients who are managed at home that way across our footprint.
That's great.
And I wasn't a shill. I wasn't a setup there. So
No, thank you, Kevin.
Just a little background. I think the Sue you referred to is Dr. Susan Turney, the CEO.
Yes.
Right? Yeah.
Yes.
She definitely is a force of nature. I have another question for you from Aruf Haider. From a technology lens, what are the foundational components to establish your clinical model? Is it video tech? Is it interoperability infrastructure, remote patient monitoring tool? And the second question is, did you have a diagnosis by diagnosis strategy or a cover any diagnosis strategy?
Yeah. So the answer to the first is all of the above. So you need to make sure that when the patient comes in after the visit, you are able to do patient safety checks to make sure it is safe for both your nurse as well as your patient to be at home, and there's adequate support that's available. So that's number one. Number two, you want to have clear workflow from the standpoint of the documentation to be available for the physician 24/7, right? So if there is low blood pressures, biometrics, all of that needs to come back so that immediate action can be taken. In terms of your supply chain, you need to make sure that you can have your oxygen, your antibiotics, all of that available. Restrictions wide, we basically try to keep it within 30 miles of a hospital to avoid the concern that Kevin has. So if something were to happen, you don't want anything bad to happen for the patient. So that piece is there from that point. In terms of technology, we basically give the patient an iPad, confirm their ability for a broadband access. We have all of the remote monitoring pieces from the physiological monitoring that's available for the patient. So be it their oxygenation status or their blood pressures, so on and so forth, that's available constantly. And we streamline all of the electronic medical records within our system, so our docs are constantly aware of what's happening. And then you have what we call as a recovery care coordinator, a chief nursing officer, if you will, who is basically managing all these patients in that hospital stay at home. So they're constantly monitoring. And during that 30-day cycle, if there's any concern, the physician who is providing care will be immediately notified. So that patient is cared for the entire 30-day period, even though the acute stay may be only 3 days. So all of the above factors are very, very important to make that happen. That ties to the infrastructure piece. So when we had these testimonies, what we wanted to share is that these things are not cheap. You need to invest in the infrastructure if you want to deliver those results. So to just do, say, telestroke, where we basically want to save time after a stroke has happened to the brain, because every minute is loss of brain tissue, right? So you want to do this and you're not searching for a neurologist in a big city. And if you wanted to save that time, that investment is close to about 50 to 75,000 for the remote equipment. The infrastructure is about 1.6 million. And so if that is not covered on parity, there is no way organizations will even go down this pathway. You're better off keeping heads in beds and pleasing your financial officer and say, okay, you're making money because you have more heads in beds, as opposed to think of creative ways of lowering cost of care. That infrastructural component is why you need payment parity for that. And it can't be restricted to behavioral health, because behavioral health is important, and that's 30% of the population, but other areas you can provide similar care, that would be wonderful. So think about it this way. If you had a gallbladder surgery, a hip surgery, or if you had a colon surgery, if I were to tell you that after your 24-hour stay in the hospital, I can manage all your care at home with the necessary support, would you rather be at home and be less delirious because you have been less disturbed by the people who are coming and checking your blood pressure every 2 hours, having all the beepers going up, the loud noise of nurses and physicians gaggling at night? Or would you rather be at home with your loved ones to provide that service? The answer is very simple. There's no place like home. And so those are all the things that can be done if we are willing to go down that pathway.
Gosh, have you testified in front of Congress? Because you are very persuasive.
So I moved from a non-believer to a believer because I had to make it happen. And now I know that this can be actually nationalized. When we went through the PTAC committee for CMMI, the first question they asked me is this: I understand this can be done in the rural environment, but can it be done in a city like New York City? And my response was, you know what? It's easier to deliver pizza in New York City in the middle of the night as opposed to delivering a cylinder of oxygen to a patient, okay, who is 2 hours away in the winter with 2 feet of snow. So tell me, what is the difficulty? And now we have 350 hospitals doing that.
Well, that's a great segue to my next question from Jim Oakes, which is, and Matt, this question to you as well. You know, how widely are these innovations being discussed at either your state level or the national level? And clearly, I think this is such a great model that I know you've been really sharing the story, but, you know, Doc, I'll start with you, and then Matt, you know, what are you seeing about hospital at home being discussed in the States?
Yeah, so Matt, do you want to go first?
No, you go ahead, set the stage.
So from the standpoint of the state, we have right now several groups that are in partnership with us to provide the care. So Common Spirit, which is the old Dignity group, they've come down to Marshfield, they looked at the model, they have adopted that model. Cleveland, Geisinger are some of the groups that are in the process of adopting the model. Mayo is doing it on its own from that standpoint. In terms of basically sharing this across the nation, I have a presentation with Becker's coming up, I think November, a couple presentations with APG, the American Physicians Group, or AMGA sometime in September, because this is now where care is going. And I think physicians as a whole in different bodies recognize that this is how you can provide care in a much more efficient way. So I think there is attention towards that. I had a conversation yesterday, thanks to Brad Walter, with Liz Fowler and her team at CMMI again. We've been in conversations for the last about 3 years to show the benefits, the outcomes, the cost savings of these models to CMMI. And so I'm hoping that it will be front and center for most people as we go past the pandemic. My major concern is if payment parity does not exist, if the requirements for originating site are not removed, this is going to fail. Because there is no way to take this forwards because the regulations will kill us. And so at some point, we need to figure out how to get past the red tape.
I was just going to add in that really it's just so slow and steady as government tends to work. And so we hope that it will continue to maintain the momentum as Dr. Murali has been talking about. And but to get these regulatory components in place, it just takes an immense amount of time and effort. And so we're going to have to see going into these really the first full sessions in 2 years for some of these states to come in and have to start making some of these decisions. But certainly it's an opportunity to influence, which is you know, what we will be trying to do. So.
Yeah, absolutely. Doctor, I wanted to tie back to your conversations with CMMI. One of the things I've observed about speaking with Liz Fowler personally is she's really taking the time to take all of this in and really assess what has been working with current value-based models and what isn't. What would you like to see in terms of incorporating your innovations, hospital at home, telehealth, into the value-based models, that the next generation, I should say, of value-based models?
Yes, so I'm working with AMA on this particular piece, Deanne. I think what has to happen is the payment model should be prospective, so people can invest without clarity of where the future of healthcare is going. If the models are not prospective, there's no way to generate value. And so that's why I started my conversation by saying, if you're having a transactional fee-for-service model, forget about innovation, right? So you need to have that. The second piece is capitation. So if you want to really hold costs down, provide a budget. It's a simple way of saying live within your budget. So most homes understand that. And so capitation would be an important factor. And then allow people to innovate, but don't do that outside the healthcare environment. So here's the problem that you'll have. And I've shared this with Liz and team. Hospital at home is a great model, so long as we know hospitalization is absolutely necessary and we can provide the care at home. But if you go the reverse way, that every tech company starts to create a model that basically says, let's start at home, let's decide whether somebody needs to be admitted, you're going to admit far more patients than you really need to admit. So you need to go through the robust process of saying, this is an absolute indicated care, then go down the pathway. So that's another factor to keep in mind from that standpoint. The PTAC committee, which is the physician task force that was looking at alternative payment models, looked at our grant in 2017. By the time Alex Azar's team saw that and said, these are the top 3 programs, and we recognized that, it was late 2018, just Thanksgiving of 2018. It required the pandemic in 2020 for us to get approval to do that for CMS patients. So it just gives you a timeline of how long it takes, even when you come back with models that work and you demonstrated that it lowers the cost of care by 15%. And 15% of $4 trillion is not, chump change. It's a lot of money. And so those are the pieces that I think we need to focus on.
Thank you for that. Any other questions? Okay. If not, I'd like to thank Dr. Murali.
I just have one more question. Is there any, and it shows my naivete here, but is there any virtue or value in hybrid models where you kind of say, we're going to do a 24-hour admission or, short term, and just to sort of put some barrier to sort of say, this really qualifies for admission, right? But then to say, once we verified stable, we're going to get this person out within 24 hours to a home setting. Is that just kick the can down the road, or any value in that, or is, just curious?
Well, there is significant value in that, Kevin. I think it's your question, correct? So right now you have the 2-day observation status. So let us say you came with chest pain. You really don't have a diagnosis of what that chest pain is due to, whether it is a myocardial infarction, whether it's pancreatitis, whether it is an esophageal rupture, right? So the diagnosis is not available till the basic investigations are done and acute care is identified. After that, the patient can go home. So that requirement is something that we have to keep in mind, because otherwise we are going to be doing a lot of disservice to patients who have real needs that are not managed. So I'll give you another example, pulmonary embolism. life-threatening, could kill you, correct? But once the diagnosis is made, and once we've started you on a blood thinner, you're safe to go home. And you don't need to be in the hospital for 5 more days with your blood thinner, right? So that's what we do. So I have somebody who comes in with pulmonary embolism at 12 o'clock at night, take them into the CT scan, get the diagnosis done, therapy started, no delay in therapy. Next morning at 10 o'clock, I have everything organized, they ship back home. And we have to keep in mind that in rural America, people have traveled 100, 200 miles in the middle of the night to come for that care. So there's not a way to ship them out immediately. So that answers your question, I hope.
Yes, thank you. Very helpful, thanks.
So what percent of your inpatient census is now being treated at home?
So
you indicated there were 20 or 25 patients per day.
15 to 20% of our patients can be treated by that. That goes back to the prior question that Trish asked me, how many commercial health plans support it? There are very few health plans that have still joined us in this 4-year journey, because for them, they're on antiquated platforms of the 1990. And so they have to go through a different HCFA form to do the billing. But I think with Anthem and United joining, things will change. So right now, I think for our SHP patients, our Security Health Plan patients, Medicare Advantage, we capture about 20% of our patients at home.
Wow. Okay. This reminds me of a statement I've heard a number of people make about telemedicine in general, and that is that the barriers to telemedicine have overwhelmingly been legal and regulatory, not technological. That generally the technology has been there for quite a while, and the pandemic, one thing that's come out of it that I think we all hope will be a good outcome will be that the pandemic has knocked down a lot of those barriers, and we hope that will stay.
Yeah, so that is where I'm not completely convinced, Jim. You're right. Technology is always ahead of healthcare, right? And healthcare is risk averse because you don't want to screw up. It's like flying a jet. So that part of it is very clear. I think where the rub is, if Congress takes too long to make its decision, you're back to square one. That inertia will set in because already from a 22% of patients who can be seen on telehealth, we are now at about 6.5%. If you look at McKinsey's report, it was predicted to be much higher. It is down. Teledoc's most recent quarterly reports think that there's only a 4% of the market share. So all of this will very quickly revert and people will forget about it. So I think it is important for us to recognize that too. But you're right, Jim. Technology is always ahead. Regulatory barriers are the real problem.
Jim, I could add a couple of comments here, although I'd also be interested in hearing what my partner Trish Marcus has to say about this, because she specializes in telemedicine too, by the way. But in my own personal view, I think some of the barriers have been the attitudes of physicians in particular, and their hesitancy for a variety of reasons to engage in telehealth. Well, during the pandemic, they pretty much had no choice, at least most of them. And they quickly learned how to do it. They learned how to use cell phones, be in touch with people. The other problem that was also where some progress was also made during the pandemic was on reimbursement. They were very hesitant because they didn't feel they would get paid adequately. Of course, that's still controversial, as we've been hearing, but I think the pandemic just got people over a lot of barriers in the provider community to be willing to engage in this, and so many of them were losing money by people not coming into their offices that they pretty much had no choice. But the relaxation of some of the reimbursement and the regulatory barriers certainly help. Trish, feel free to comment.
I hesitate to bring this up, but I also wonder, thinking about hospital services at home in particular, talking about telehealth in the larger sense. What happens to the state-of-the-art facilities that continue to be built, the health systems that have fountains in the lobbies, brand new medical office buildings with, newfangled imaging equipment that private equity and systems are investing in. Maybe they're a certificate of need state and they're getting the CON. I worry to some extent that the lobbyists for some of those organizations are louder, perhaps, than those who are trying to, create a more cost-effective and perhaps, dare I say, a safer healthcare system. I'm always struck by the different tensions that exist anytime you talk about trying to change healthcare.
So Trish and David, you're both right. So prior to the pandemic, I had 200 of my 1,400 physicians willing to do telehealth, right? We've been doing this since 1997, all right? When the pandemic hit and we had to close down our facilities, all the 1,400 were trained and adopted that program. So absolutely right. There's no question about that. Change is always hard. It's like, I think the only people who like change are little babies when they need a diaper to be changed. But other than that, physicians definitely not. So let's accept that. In terms of the point that Trish is sharing, absolutely correct. And that is the reason why I shared that you need to have technology folks work with integrated health systems or hospital systems or provider systems to start that care from that end, as opposed to an independent end where they're really looking at a venture capital or a for-profit model. Because then what happens is now you're basically creating a lot more difficulty from the standpoint of delivering on the outcomes. Because if ultimately your focus is to lower the cost of care is not going to be reduced by a piecemeal approach. And I think, Trish, that's what you're trying to allude to. And I agree with you. And there are ways to do it. So Contessa, which was the platform that we worked with, which had the basic billing platform, is basically a startup that went down the VC pathway. But we were very, very clear that we would do it only as a joint venture, understanding that we are a not-for-profit entity and that the margins would be capped. And whatever the margins would be, it would be shared. So that way we could invest more into the process. So that's the model that I think the country should think of. Otherwise, you're going to have a mess, because everybody and their uncle is going to be starting up a small company, and your cost is going to go up because it's not episode treatment group. It is, again, fractured care, which will have poor outcomes.
Very interesting. Thank you.
I have a question for the doctor.
Go ahead, Leo.
Thanks. That's a great presentation. Thank you very, very much. My question is regarding the infrastructure. Do you think, from the standpoint not merely of HIPAA compliance and so on, but truly protecting the integrity of the connections and the data that's going across them, do you find the security infrastructure capabilities adequate, or are they an impediment? And are there pain points that you have discovered that you think could be socialized and addressed from the technical community?
Yeah, so that is going to be a tough question to answer. So when you are doing it within the environment of a health system, we have much of the security locked in. We have a security team that is constantly looking for people hacking the information. When we go down to an open platform, that is a huge risk. And I'm waiting to see what that tsunami is going to do to healthcare in general. My sense is it's going to be very similar to what happened to cell phone companies back in 2000 when the data became open, or in other words, the phone numbers were not tagged to the particular cell phone company. It basically revolutionized the industry. And so I think the cybersecurity will follow with it, but it's a guess at this point. I hope you don't see me as waffling on that question, but that's the best I can say based on what I know presently.
Thank you very much.
Okay, this was fascinating. Thank you very much. Thank you, Deanne, for arranging it. Thank you, Dr. Murali, and thank you, Matt, for your presentation. This was just got into a lot of really innovative ideas and good discussion. So I appreciate it. So keep all this in mind, but we will not be talking about any of this at our August meeting. We will instead be talking about much more important topics like how are the Nationals going to do the rest of the year and follow on things like that. So David or Deanne, any closing comments?
Yes, thank you. Thank you, Deanne, for taking the lead on all this. It was really very informative and a very important topic. Thank you.
Well, thank you. I'd like to thank the good doctor, and thanks, Matt. I know you're in transit today trying to unload boxes, but I appreciate you both, and I agree. This is a big learning opportunity for me as well.
Yep. Okay, lots to follow up with, lots to think about. Thank you all, and we'll look forward to seeing you in August.